Hello friends, in the sequence of ENT lectures, today we are going to discuss a important topic. Uh, uh, this is the last class of modern rhinology. Rhinology is the science of nasal cavity and its disorder. Please give me a minute. And its disorders. And when we will start the comparison between various disorders outlined in Ayurvedic textuals with modern counterpart, this will be an important point to discuss. And let me start with sharing today's topic, which is CSF rhinorrhea or leak of a CSF fluid through the nasal cavity. This is called as CSF rhinorrhea. Let me enlarge the topic now. So, in the rhinology section, we have already discussed anatomy of the nasal cavity, physiology of the nasal cavity. We have discussed epistaxis. We have discussed ABRS, that is acute bacterial rhinosinusitis. We have also gone through this chronic rhinosinusitis with the complication options. And today's topic will be CSF leak or a CSF rhinorrhea, which will be very helpful in outlining the comparison of the Ayurvedic disorders we are going to discuss from the next class. My name is Dr. Atul Bhardwaj. I am faculty in the shape of assistant professor in the department of Shalakya, that is INDNT, and today's topic will be rhinorrhea. The word rhinorrhea is like secretions from the nasal cavity. Rhino is nasal cavity, and like a diarrhea, this will be the secretion from the nasal cavity. And these are not the normal secretions which are secreted by the goblet cells, which are responsible in a major way to have normal secretions. These goblet cells are responsible, but this is a leak of the cerebrospinal fluid, or also called as CSF, from the subarachnoid space into the nasal cavity. So this will be a leak. Leak is obviously a abnormal presentation of the CSF, which is present in subarachnoid space, in the subdural subarachnoid space, and the presentation of this fluid into the nasal cavity through a breach of the cribriform plate or the sphenoid sinus roof is called as CSF leak. So this will be a fistula, abnormal continuation of the path between the subarachnoid space to the nasal cavity and nasopharynx both. So the nasal cavity and nasopharynx both. So that is a fistula or abnormal continuation of or a pathway which is existed as a result of, or presented as a result of trauma, or as a result of pathology also. The CSF is drained into the through a fistulous route or a fistulous tract from the subarachnoid space into the nasal cavity is called as a CSF rhinorrhea or a CSF leak. CSF may present as a leakage into the middle ear also in case of a temporal bone fractures of the temporal bone. The CSF, because the roof of the middle ear is formed by tegmen or tegmen plate, which is and just superior to the, or the roof of the tegmen is nothing but a dura, and underneath the dura will have arachnoid, and underneath the arachnoid is a potential space, is a space which has got this circulation of the CSF. You have to go through the CSF circulation in order to completely understand this CSF leak topic or a CSF rhinorrhea topic. So the leakage of the CSF through the ear is called as CSF otorrhea, and the leak through the nasal cavity is called as CSF rhinorrhea. CSF rhinorrhea. And the diagnosis of CSF rhinorrhea needs a high amount of vigilance, especially in OPD when the patient presents with the symptoms we are going to discuss. The patient should be subjected to various radiological procedure in order to completely elucidate or completely diagnose the case that the patient is having of CSF rhinorrhea. So I will not go into the historical perspective, though the disorder has been long debated as far as surgical approach is concerned, which is used in order to correct this or in order to repair this leak. Uh, 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 you can say external approach through the uh, this making a window into the skull bone is mandatory, or these leaks can be repaired through endonasal approach or through endoscopy is widely debated. But by the advent of good quality of endoscope and a variety of skull base you can say repairing material available, or flaps available like a Haddad flap and a Casanova flap, now are widely accepted that majority of the CSF leak of the skull base can be repaired endoscopically or through the nasal cavity, and there is no need of a extranasal approach, or there's no need to make a window into the skull bone, and you then have to retract the brain itself, and then you have to repair the leak through the cranial side, which is by and large has been negated by or countered by development of a endonasal approach. So these are various routes through which the CSF can present into the nasal cavity, or a CSF leak can occur. So this is supposed to be the most important leak location, or location of the leak, or a focus of the leak is through the cribriform plate. Cribriform plate. Cribriform plate is a part of the ethmoid bone, and it's a sieve-like structure, and through which the nasal, this olfactory nerve fibers enters into the nasal cavity or presents themselves in the nasal cavity, and through these sieve-like multiple perforations in the cribriform plate, and also it's a very fine thin bone like lamina peperacea, which separates the orbital cavity from the nasal cavity. So it is the nasal cavity, these are turbinate, these are orbital cavities, and these are frontal sinuses, and this is supposed to be the skull base. So this cribriform plate and this lamina peperacea, the part of the bone which is present between the orbital cavity and the nasal cavity, is called as lamina peperacea, and this cribriform plate uh, are very thin, paper thin, you can say, along with this fovea ethmoidalis, which is lateral lamella, These are very thin bone, and as a result of fracture of the frontal bone or the surrounding bone, majority can lead to a leak of the subarachnoid fluid. This is CSF into the nasal cavity, which is called as a CSF leak. So cribriform plate, because it's a very thin, fine, paper thin bone, which also has got multiple sieve-like perforations for the entry of the olfactory nerve also. So this cribriform plate area, apart from that, the CSF through a frontal bone fracture, the posterior table, this is posterior table of the frontal sinus, this is anterior table of the frontal sinus. So the fracture of the posterior table of the frontal sinus can lead to entry of the CSF into the frontal sinus, and through the frontal sinus it appears into the middle meatus, because nasofrontal recess or nasofrontal duct, but recess is far better word. So the presentation of the CSF first into the frontal sinus, and because the frontal sinus drains it into the middle meatus, then the CSF appears into the nasal cavity is another route. So the first one is a cribriform plate, or via cribriform plate, you can say, and the second one is through the frontal sinus, then into the nasal cavity. Another one is when the CSF appears into the sphenoid sinus first, and the sphenoid sinus opens into the sphenoethmoidal recess, and then the CSF appears into the nasal cavity. So in the third case, the CSF appears first into the sphenoid sinus, or the CSF leak happens to be through or via the sphenoid sinus. First, the leak appears into the sphenoid sinus, and because sphenoid sinus anteriorly opens into the nasal cavity through a sphenoidal recess, so the CSF appears into the nasal cavity. This is the third route. The fourth route is a rather rare, you can say, in which the clivus is a junction of the sphenoid with the occipital bone. So this spheno-occipital junction is called as clivus, and this body of the clivus, in case of a fracture, the CSF appears into the nasal cavity through the clivus, which is way more you can say rare presentation in a clinical practice. So CSF leak can occur or tends to occur from variety of locations or focus, and the most commonly are through the frontal sinus and through the cribriform plate. Cribriform plate being a very you can say weak and a thin structure, thin plate of bone. um, the propensity or the chances of fracturing of the cribriform plate, and thus the leakage of the CSF into the nasal cavity, are quite high in case of a facial fractures or a leaf-fold fractures. Facial fractures are classified through leaf-fold classification method. And these are two major categories through which a CSF leak can be classified. You can say the first one is a traumatic leak, and the second one is a pathological or a non-traumatic, which is also called as a spontaneous leak. So in the first case, the history will be a trauma will be there, which may be a road traffic accident or a surgical or a iatrogenic trauma, you can say, is the first case. And the spontaneous is when the CSF leak appears or a CSF rhinorrhea appears without a result of a trauma, as a result of various pathologies like granulation of the arachnoid villi or a bone dehiscence, etc., or osteomyelitis. We will discuss in detail in the next few slides about the spontaneous leak. But traumatic leak is by far more common than the spontaneous CSF rhinorrhea. So again, traumatic can be again classified into a non-surgical, which is like a road traffic accident kind of a presentation, and surgical are when the patient has underwent some sphenoid surgery, like the roof of the sphenoid, which is a pituitary adenoma surgery, or olfactory fossa surgery in case of a tumors. Then this is a surgical or iatrogenic CSF leak. And non-surgical, most of the cases are presented as a road traffic accident, which may present within 48 hours. Then it is called as acute. And if after some period of time, of elapse of the time when the trauma has happened, this is called as a delayed presentation. Spontaneous are again classified into a CSF leak, which has got a high pressure of CSF. Then it's a high pressure leak and a low pressure leak. uh, this classification depends upon the pressure of the CSF, opening pressure, you can say, of the CSF is there. So trauma, as already discussed in the previous slide, this can be either a iatrogenic or a surgical trauma. Post-operative leak, you can say, in case of a craniotomies for various kind of a skull-based tumor, or a eighth nerve tumors, or a meningioma surgery. So in these cases, this CSF leak can occur in case of a post-operative in post-operative period. Apart from that, extensive skull-based surgery like JNA surgery, juvenile nasal angiofibroma, or extensive fungal sinusitis surgery, like in the case of mucormycosis or sphenoid surgeries, involvement of a sphenoid sinus or sphenoid polyp. Next is a skull-based tumor surgery or a transsphenoidal surgery. Transsphenoidal is like you can say, a pituitary adenoma surgery, a macroadenoma or a microadenoma surgery. And then the patient can have a CSF leak post-operatively. Traumatic is a road traffic accident or engagement of a fight. Then it can present within 1 week. Then it is a early, and if the CSF leak presents after some time, then it is called a delayed presentation of a CSF leak or a CSF rhinorrhea. Spontaneous is like there is no history of trauma in these cases, but still the patient can have a leak. The presentation is mostly erosion of the bony plate, of the cribriform plate. There may be osteomyelitis of the frontal bone, and there may be cellular atrophy can be there. The congenital dehiscence or defects in the skull base can also lead to leakage in case of a high flow leak. And idiopathic is also a class which is presented itself in the spontaneous division. So majority of the causes of the CSF leak is by far, I've already discussed, is by head trauma or a facial fractures, as well as the skull base fractures. Skull base in the sense is anterior to posterior will be the frontal floor, frontal sinus floor, then the cribriform plate, then will have sphenoid. The plain area of the sphenoid just anterior to sella is called as planum sphenoidale. Then the sella turcica itself, and posterior to post sella, or that will be the clivus. So head injury and head trauma or fractures of the cranial bones, apart from that fracture of the skull base, are important factors which leads to CSF leak. So because this ethmoid and cribriform plate, ethmoidal roof or the cribriform plate, along with fovea ethmoidalis, again which is roof of the nasal cavity, anterior skull base, you can say, is a very thin area of the ethmoid bone, and the dura in this area is tightly adherent to the bone. So if there is a fracture of the bone, then there will be a associated dural tear also. There will be tear in the dura, and this essentially will lead to tear in the arachnoid also, and this arachnoid trauma leads to abnormal fistulous tract between the subarachnoid space and the nasal cavity. So which already discussed, because of there will be lysis in the clot in case of a delayed post-traumatic. Why there is a delayed post-traumatic CSF leak? Because of the clot which is blocking the leak in these patients, and the clot undergoes lysis, and again the reopening of this fistulous tract will be there, which leads to delayed post-traumatic CSF leak. Apart from that, this tissue edema, the soft tissue brain matrix edema, when subsides, opens up the fissular tract, which can lead to also a delayed presentation of a CSF leak in case of a trauma. Apart from that, post-traumatic cases, there may be a loss of vascularity because of breach in the blood supply, you can say, or the vasculature may be disturbed, which leads to loss of the tissue, and which leads to a fistulous formation. So we have already discussed, but are the important iatrogenic. Iatrogenic is the surgical causes or doctor induced, you can say. So anterior skull base tumor, or olfactory groove tumors, or olfactory fossa tumors, apart from sphenoid surgery, are the most important causes in case of a iatrogenic CSF rhinorrhea. So what are the complications if the patient do not undergo a CSF surgery or a CSF leak surgery? So majority of the traumatic CSF leak do not need any kind of a surgery. They will recover on itself, like when there will be healing of post-traumatic phase, then most of the cases will resolve on itself, especially in the case of a traumatic CSF leak. Whereas in case of a spontaneous CSF leak, it will remain so, and the presentation itself will be is a presentation. This spontaneous CSF leak invariably should be corrected as by a surgical intervention or a repair of a CSF leak. So in majority of the patient, if is the chances of having a pyogenic meningitis, if the patient do not undergo some kind of a repair, then can have a meningitis, and the overall risk is about 25% in case of a spontaneous leak. The traumatic leak, we have to wait for some time, because majority of the traumatic CSF leak repairs by itself or needs no surgical intervention, you can say. And the chances, the mortality rate is, you can see also, is quite high in case of a pyogenic meningitis, which happens to be in 25% of the cases who do not undergo some kind of a repair. Apart from that, pneumocephalus and encephalitis or encephalitis, you can say, or proper brain abscess can occur in if the patient do not undergo some kind of a repair. So you have to, in order to go for surgery, you have to diagnose it. And diagnosis of a CSF leak, the location of a leak, it was a challenge before, but by the advent of this 3 Tesla MRI and a thin slice, or you can say HRCT, or a high resolution CT scan, nowadays the location of the leak can be easily determined by you can say joining these two, or you can say by having some kind of assistance by both CT scan or a high resolution CT scan and MRI. Both you have to do in these patients in order to clearly delineate or locate the exact site of the leak. So they, you can say, they are complementary. This MRI, a 3 Tesla MRI along with a high resolution CT scan will be complementary to each other, and most of the cases can be delineated for the site of location. So what are the clinical evidence, or how can you say that the patient is having a CSF leak and not a normal nasal discharge, or like of a allergic rhinitis? So the diagnosis part and the repair or the surgical or the management part we will discuss in the next class. Please subscribe the channel also, and press the bell icon for the updates also. Thank you for watching the video. Thank you very much.